Hi, everyone, and welcome to the session. We're going to go ahead and get started. Before I introduce our moderators, a couple of house cleaning items. This talk is recorded and available through the Neonatal Hemodynamics Research Center's YouTube channel. And actually, all of our previous PanAmerican Hemodynamics webinar are available in this YouTube channel. Throughout the talk, if you have any questions, please post in the Q&A. If we're unable to get to your questions, we will be recording those and answering them at a later date. And so please go to our Neonatal Hemodynamics Twitter site, where you'll be able to see the answers to those questions. I would now like to introduce our moderators. First is Dr. McConey. She completed her neonatal hemodynamics training in Iowa and is building a hemodynamics program at the University of Oklahoma. Our next moderator who will join us shortly is Dr. Levy. He is a neonatologist at Boston Children's Hospital. He does a lot of work with cardiopulmonary interactions with a specialty in the right ventricle. Thank you, and up to you, Dr. McConey.
Thank you and good afternoon. It is with great pleasure that I introduce our speaker for today, Dr. Carl Bacchus. He is an associate professor of pediatrics at Ohio State University. He is board certified in neonatology and pediatric cardiology. Currently, he serves as the director of the Perinatal Research Network at Nationwide Children's, leading a team of 32 employees with a mission to facilitate and accelerate clinical and translational research throughout the perinatal division and collaborating partners. Dr. Bacchus' outcomes-based research is supported by the National Institute of Health and the American Heart Association. And as our panelists today, we have Dr. Adrienne Bischoff. She is from the University of Iowa. She graduated medical school at the Federal University of Rio Grande do Sul in her hometown in South Brazil, completed pediatric residency at the Hospital de Clínicas de Porto Alegre. She pursued her neonatal perinatal training at the University of Toronto and the Hospital for Sick Children, where she grew a special interest in the field of neonatal hemodynamics and targeted echocardiography. Her research interests include cardiovascular physiology after definitive PDA closure and the use of cardiac magnetic resonance. Our second panelist is Dr. Bonnie Jasani, who is a staff neonatologist at the Hospital for Sick Children in Toronto, Canada, and assistant professor of pediatrics at the University of Toronto. He completed medical school and residency in pediatrics at the Maharashtra University of Health Sciences in India. He completed his Doctor of Medicine training in neonatology at the KEM Hospital in Mumbai and clinical fellowship in neonatology and perinatal medicine and advanced neonatal hemodynamics at the University of Toronto. Dr. Jasani's specific research interests include the use of acetaminophen for management of patent lactocytosis and transcatheter closure of PDA and preterm infants. And our third panelist is Dr. Shyam Sathanandam from Lebanon Children's Hospital. He is the medical director of Interventional Catheterization Laboratory. He's a pediatric cardiologist and also the director of Large Animal Cardiovascular Research and associate professor of pediatrics at the University of Tennessee. And he's also the course director for the International PDA Symposium. So I will hand over to Dr. Bacchus for his presentation. Thank you.
Well, thank you for that kind introduction. I do see a problem with this first slide. This is at Nationwide Children's in Columbus, Ohio, and it shows our beautiful hospital, but it also shows a bright sunny day, and I promise you we haven't seen one of those in about 3 months. So I have no disclosures. I do want to take a moment to thank the organizing committee really for their Herculean effort in organizing these virtual webinars. Our pediatric community benefits greatly from their time and effort. So I just wanted to throw that out there and thank Patrick and the committee. So what are we going to talk about today? I have really 3 objectives. It's looking at the PDA as a moving target over the last decade. Then let's focus our efforts on percutaneous PDA closure. Let's look at it from the standpoint of first, safety and feasibility, and then the natural next step of clinical efficacy. And then let's talk about a potential roadmap moving forward. So, over the past decade, we as neonatologists have dramatically changed our management and treatment of the PDA. This is a study, this is from Reese Clark's group. It's over 60,000 infants born between 23 and 30 weeks gestation. The cohort was divided into two groups. You've got the 2006 to 2010 in the black circles, and 2011 to 2015, those open gray circles. So across 163 sites, 79% showed a decrease in the diagnosis of the PDA in the later epoch compared to the earlier one. 81% showed a decrease in the use of indomethacin or ibuprofen. 83% showed a decrease in PDA ligation rates. Why? What's led to this huge shift in our practice? Well, fear. Neonatologists are afraid of everything. We're going to get into that later, but we are particularly afraid of the potential risks of surgical PDA closure. We are all well aware of the association, and I want to underscore association between surgical PDA ligation and adverse outcomes, neurosensory impairment, catecholamine-resistant hypotension, and decreased myocardial perfusion, and worse outcomes, including worsened respiratory morbidities. Back in 2009, during my cardiology fellowship at Nationwide Children's, we were performing at one institution close to 80 surgical PDA ligations per year among infants less than 3 kilograms. In 2018 to 2020, we performed one surgical ductal ligation. Well, what happened? The treatment modality for definitive PDA closure swung from surgical ligation to catheter-based closure, shown here in red, in less than 10 years. What drove this shift in practice, you ask? The promise. The promise of catheter-based closure as a safer, lower-risk alternative to surgical ligation. Well, if we ask one of our adult colleagues, they've already had the answer for over 20 years. Catheter-based closure has been the procedure of choice in adults and older children and infants greater than 6 kilograms for quite some time. So not only is there interest among providers, there's also interest among families. This is a recent newspaper headline where my grandma lives in Chicago. This is also a headline, or this is from the CBS News in New York. I hope to get it to play. So if I'm sitting in the audience today, I'd say, show me the data on safety and feasibility of percutaneous device that's led to this huge surge in interest and usage. Well, when you're old like me, you get to talk about the way things were. So let me talk about our 10-year experience with percutaneous PDA closure. We did a simple, single-center retrospective chart review among our infants at Nationwide Children's less than 3 kilograms undergoing percutaneous closure. Why did we do it? While I was a cardiology fellow, I started to see an uptick in the percutaneous PDA closures being referred down to the lab, but I was not able to provide colleagues and parents on the risk profile. In a sincere effort to provide a more granular reporting structure, we observed that among 52 very preterm infants, again, retrospective chart review with attempted percutaneous closure, right around 88% had a successful device placement. But an adverse event occurred in 33% of patients. And at this time, 10 years ago, the most common form was an acute arterial injury. Well, that's just a single center study, Carl. Maybe you guys are just behind over there at Nationwide Children's. Again, similar time period from almost 10 years ago, we did a safety and feasibility review in a multi-systematic review among infants less than 4 kilograms undergoing percutaneous closure. And what did we find? Again, consistent with our single center site, a technical success of right around 90%. But again, 10 years ago, we were finding adverse events rates approaching nearly 25% and major adverse event rates approaching 10%, many of them related to that arterial thrombus. We had a problem. So what changed? Well, to be honest, I think we just started to communicate. Led by Sham and the group from Memphis, we started to meet. Neonatologists had a platform to discuss the unique vulnerabilities of the preterm infant with interventional cardiology colleagues. Interventional cardiology colleagues had a platform to demand devices from other institutions of ductal morphology of the preterm infant. Nurses had a platform to share their experiences. High-performing centers could educate other sites on best practice. We could talk on procedural modifications to limit adverse events. We talked on a regimented, consistent approach to optimize feasibility. Now, we didn't just work. For Christ's sakes, we were in Vegas. We had some fun too. But in general, there was a new idea of sharing of information regarding best practices. I contend that this collaborative meeting, which was held over 5 consecutive years, had a downstream consequences that led to positive impacts on our patient care. And as a result, over the past 5+ years, the feasibility and safety of percutaneous closure in smaller and smaller infants has markedly improved. Compared to 10 years earlier, feasibility rates now approach 100%, and adverse event rates have been minimized. In this study from the Memphis group, among 100 infants with a median weight of 821 grams at 24 days postnatal, success rate was 100%, and the major adverse event rate was 3%. Adrian Bischoff's recent meta-analysis in 2020 in the journal of Pediatrics, you can see from this slide clear evidence of improved technical success of percutaneous closure among infants less than or equal to 1.5 kilograms. Unlike 10 years ago, if we as neonatologists send our patient to the cath lab, in the vast majority of cases, they will come back to our NICUs with a closed ductus. This was a single-arm, prospective, multi-center, non-randomized study to evaluate the Amplatzer Piccolo occluder to treat PDA in preterm infants greater than or equal to 700 grams. The study was conducted from 2017 to 19 at 9 centers, and they had 100 patients less than or equal to 2 kilograms. The implant success rate among infants less than 2 kilograms was 99%, with a risk of embolization or device migration as shown here at 2 and 1% respectively. This study, with strong evidence of feasibility and a very reasonable safety profile, led to FDA approval of this device, the Amplatzer Piccolo occluder, for infants greater than 3 postnatal days and 700 grams. Yes, let me repeat that. In 2002, we have an FDA-approved device starting at 3 postnatal days and 700 grams. But the interventional cardiologist didn't just stop there. Here's the recent published consensus guidelines on the prevention and management of complications with the Amplatzer Piccolo occluder in extremely low birth weight infants. This article summarizes optimal implant techniques, specific details on avoidance of our past problems of arterial access, as well as device placement to avoid device-related stenosis of the aorta with the left pulmonary. With an eye towards safety, Sham and colleagues noted that, and I quote, "It is imperative that implanters of the Piccolo occluder are aware of all potential complications and develop a strategy to promptly recognize and manage them." Our neonatal community should be grateful for the efforts of the pediatric interventional cardiology community, who has refined the procedure and has led to high feasibility and low major adverse event rates. Now it's our job on the neonatal side to define clinical efficacy. In other words, just because we can place the device does not mean that we should. So over the next few slides, let's look at the clinical efficacy of the procedure. We have observational studies pointing to, and I underscore observational, the efficacy of percutaneous PDA closure compared to surgical ligation. Evidence of faster recovery of respiratory function, improved ventilation compared to surgical ligation, and less incidence of post-ligation cardiac syndrome. Again, the Memphis group looking at percutaneous closure versus surgical ligation in 2019 study showed that percutaneous closure is feasible again in infants as small as 640 grams and may offer faster weaning respiratory support compared to surgical ligation. Observational study from our group at Nationwide Children's Hospital looking at trends pre and post percutaneous PDA closure. Compared to pre-PDA closure trends, you see a decrease in the need for mechanical ventilation. Again, observational studies. But as the group from Children's Hospital of Philadelphia reminds us, randomized controlled trials are the best way to evaluate the efficacy of an intervention and should be clear in their effects to accumulate sufficient evidence to change clinical practice. In a meta-analysis our group did nearly 10 years ago, we tried to answer just 2 questions. Show me the randomized controlled trial data comparing percutaneous PDA closure versus surgical ligation. No randomized trials. Show me the randomized controlled trials comparing percutaneous closure versus drug therapy for the ductus. No randomized controlled trials. We'd say again, Carl, that data is 10 years ago. We've made a lot of progress in 10 years. You just told us about the progress we've made with safety and feasibility. This is Adrian Bischoff's recent meta-analysis in 2020 in the Journal of Pediatrics. Again, distilled down to 2 questions. Show me the randomized controlled trial data comparing percutaneous PDA closure versus surgical ligation. Adrian found no randomized controlled trials. Again, show me the randomized controlled trials comparing percutaneous closure versus drug therapy in 2020. No randomized controlled trials. So what we have, and as we stand in 2020, we have a growing number of case series, cross-sectional, case control, and cohort studies, but we have no randomized controlled trials to guide the practice of evidence-based medicine. So while the data on safety and feasibility has improved, randomized controlled trials are greatly needed. Let's talk about potential next steps. How do we, as a community, answer today's fundamental question? Is percutaneous device closure the new standard for PDA? What do we say at every meeting we go to? We're going to go to PAS this week. All studies end with, there's a lack of evidence and we need a randomized controlled trial. The idea, the concept of a randomized controlled trial is relatively simple, but the actual application and conduct of an RCT is much, much more complicated. Let's ask 4 fundamental questions in the design of a contemporary randomized controlled trial of percutaneous PDA closure. Do healthcare providers have equipoise? Do we know how to consent? And this is going to be a difficult trial. Whom shall we randomize? And when should we randomize? Let's start with the first question. Do healthcare providers have equipoise? What is clinical equipoise? As noted in this editorial in the New England Journal of Medicine, clinical equipoise exists when there's no consensus within the expert clinical community, that's everyone on this call, about the comparative merits of the treatments to be tested. I hope that we can agree, based on the lack of evidence I've shown you, that we should have equipoise for a randomized controlled trial of PDA treatment. In fact, the Committee on the Fetus and Newborn has emphasized the need for equipoise among healthcare providers in the enrollment of their patients into clinical trials on PDA treatment. But this may not be the case in contemporary practice. In the recent PDA Tolerate trial led by Dr. Kleiman, investigators noted that while 202 infants were enrolled in the trial, 137 of them were not enrolled due to a lack of physician equipoise. Those infants not enrolled were younger, less likely to receive steroids, and more likely to need surfactant than infants who were enrolled in the trial. How do we consent for a difficult randomized controlled trial? We are all well aware that for most neonatal randomized controlled trials, most caregivers refuse participation. Some evidence suggests that that number could be as high as 70% refusing. We need a process to review and optimize recruitment. We need training. I need training to communicate the concept of randomization to families without falling back like I usually do to flip a coin or 50-50 chance. We need to partner as a neonatal community with experts in trial, recruitment, and consenting. Strategies to support healthcare providers to effectively present high-quality information and communicate successfully with patients in adult randomized controlled trials have already been developed. This is work from a group in the UK has increased consent rates in those adult difficult trials from 30 to 40% all the way to 70% by just drilling down concepts of equipoise, concepts of randomization, and how as healthcare providers can we present a balanced presentations to the families that we serve. Whom shall we randomize? Patrick McNamara, I think, hit the nail on this in this very elegant editorial. He notes that in an attempt to design trials that are simple, illness severity related to the PDA has not been taken into account and stratification has not been performed. This oversimplification may lead to erroneous conclusions. So what should we do? Perhaps rather than including all infants, irrespective of clinical or echocardiographic ductal sequelae, what if we just were to target those with clear evidence of adverse ductal consequences, as shown here with severe clinical criteria defined by the need for mechanical ventilation and a large echocardiographic criteria beyond simply ductal diameter to define those with a hemodynamic significant PDA. This approach may allow us to identify the subgroup most likely to benefit from a PDA closure while still optimizing our risk-benefit profiles. When should we randomize? Dr. Bennett and the Committee on Fetus and Newborn has previously noted that the evidence supports the conclusion that early, we're talking in the first weeks after birth, treatment to close the PDA does not improve long-term outcomes for preterm infants. This is a well-known study from Simbarova et al. That investigated just the natural history of 280 preterm infants whose PDAs were not provided drug therapy or definitive treatment. Using a conservative or non-interventional approach to PDA, the authors observed 85% spontaneous closure rates. So keeping with the recommendations of the Committee on the Fetus and Newborn, non-treatment in the first weeks of life may actually reduce some unnecessary interventions in some infants. But the question remains as to what to do if the PDA fails to close following a period of conservative management. This is particularly relevant among the subgroup of lower gestational age infants shown here in red and blue at less than 26 weeks and less than 28 weeks respectively. These infants are beyond the window when drug therapy is typically used and spontaneous closure has yet to occur. For me, they represent the ongoing therapeutic dilemma for healthcare providers. And I believe that in future trials incorporating catheter-based closure, we need to prioritize this high-risk subgroup. So in closing remarks, although the Amplatzer Piccolo device provides a non-surgical alternative to achieve definitive PDA closure, fundamental questions on the optimal use of the device remain unanswered. Based on the review of our available evidence base, FDA approval, in my humble opinion, is insufficient grounds for rapid dissemination of percutaneous PDA closure. Without high-quality, randomized studies, the debate of how to best care for infants following failed early treatment will continue and prevent progress in the field. I believe and contend that it's only through well-designed randomized controlled trials that our current beliefs as to the benefits of percutaneous PDA closure will be finally refuted or confirmed. Thank you very much.
Thank you, Carl. That was an excellent presentation, as always. I just wanted to be able to add to the introduction that was made in the beginning by Dr. Marconi that, Carl is really very humble, and he's more than just a world leader. He converses with all of the panelists on this call, probably almost on a daily basis, really guiding us through this uncharted territory. I'm going to kind of ask him some questions in a minute about Pivotal, but I think it's just really important to know that when you Google, when you PubMed, when you go to any conference, we have PAS coming up, and you hear percutaneous closure of the PDA, it's almost synonymous with Carl Bach. So really hats off to the work that you're doing. And it's really becoming synonymous with all of our wonderful panelists, with the work, all of us are familiar with the work that Patrick does, but Sham, the work that you are doing is just incredible. Adrian, and then bringing up the rear, obviously the work that Bonnie and the people in Canada are doing. So I think that was just a wonderful presentation and an overview of where the field has been, where the field is. And Carl, I'm going to jump it off with you actually to where the field is going. I know one of the initial questions we have in the Q&A is about equipoise, but you have a unique trial design that not only touches upon randomized control trials and equipoise, but really getting at the heart of this percutaneous closure with the Piccolo device. But can you comment on how you're taking this presentation and your work over the last 10 years and bringing it to the pivotal trial, which is going to include, I think, 22 centers in the United States? Just a few words on where we're going with that.
Thanks, Phil. That was too kind of you to say all that, but appreciate it. So here's what we've got organized from a national perspective on the pivotal study. And so let me just back up a moment. We've been working on this for the past really 5 years, right? So you're really trying to thread the needle. What is the neonatal community willing to tolerate? What is the interventional cardiology community willing to participate in? And so we've had multiple discussions, largely led by Sham's meetings over the past 5 years, to hone down the question further. I think to back up, 5 years ago, there was many that wondered, could we have a third arm? So we would include those percutaneous closure versus surgical ligation versus a drug therapy. And what we found is none of the centers participating here had equipoise for surgical ligation as closure. So really, despite everything I've shown, you can say the percutaneous closure has replaced surgical ligation at most US centers as the primary option for definitive closure. And we want to take a step back further and say, what patients should we include in the study? Across the 22 sites, despite our best efforts, none of us could agree on the best initial management, right? So some use drug therapy, some have abandoned drug therapy altogether, some use indomethacin and Tylenol. Irrespective of that, and in the veil of a pragmatic trial, we wanted to leave that up to the individual centers to define how they use and how they defined failed medical management. That was the subgroup following failed medical management that the entire team thought was most relevant to the next phase of contemporary trials. And after a failure of medical management, we wanted to provide a window for randomization to percutaneous PDA closure versus continued conservative management. And so that's what we've been able to achieve consensus in the, across the 22 sites to conduct pivotal over the next 5 years.
Thank you, Carl. That was very clear. So I'm gonna try and answer or pose a lot of the questions that are coming in right now. I'm actually going to start just with Adrian right now, just to take one step back before pivotal. In your experience in Iowa and then previously in Toronto, what would you say is really the standard of care? And maybe I'll just kind of lead the question, but the standard of care regarding closure of the PDA, take us from kind of conservative or medical management from a conservative arm through medical therapy through definitive closure, just to give the audience a sense of where the state of the field is. And you can even comment on some of the recent Canadian Pediatric Society recommendations that have come out.
Thank you, Phil, for that question. I would say that from my experience in Toronto, it was a little bit different than here, mostly because we worked in 3 different hospitals and there was quite a bit of variance in practice. Here at the University of Iowa, we are a little bit more consistent. We have all of the assessments being done by the same group, the same neonatal hemodynamics group. And we have a targeted approach to PDA, where we do comprehensive assessment of shunt volume and significance based on a bunch of echocardiographic markers from our TN echoes. But we tend to have a more proactive and early approach, where all of our extremely preterm babies are screened in the first 24 hours of life. And if they meet criteria for shunt significance based on all of these markers, they get medical therapy. And our first line here is acetaminophen in the first week of life. If they continue to have a significant shunt based on all of our markers, we try a second line of therapy with indomethacin, provided that there are no contraindications based on each patient's individual profile. And usually by the time that we get to 2 or 3 courses of usually relapsing, remitting type of course or failed medical therapy, then we refer our patients for definitive closure. And here at the University of Iowa, practically 97% of our babies are being closed by the percutaneous route. There's very few babies that are deemed to be too small or too unstable to go to the cath lab and still have surgical procedures done at the bedside. But the majority of them are percutaneous closure. And on average, these babies are being closed in the first month of life. So between 3 and 4 weeks of life is when the majority of these babies go for definitive closure.
Great. So, you touched upon a few of the issues, concerns, opportunities that we face, I think, worldwide. The first is the timing of the closure. I think we'll get at that with some of the pivotal. The second issue that you talked about is how many courses of medical therapy is one willing to try prior to definitive closure. And just to define for everybody, definitive closure we refer to as either ligation or transcatheter device closure, and I'll get to that a little bit later. But I'm gonna shift it over to Sham for a question. But just as we framed it, we've talked about you could ignore the PDA, you could have medical therapy that includes non-pharmacological therapy, you could have pharmacological therapy. The pivotal is going to hopefully answer one of these questions about how many courses and doses in terms of prior to proceeding to device closure. Then you have the definitive closure. But one of the concerns, and this is for Sham, that I have seen raised over the years is that moving these extremely preterm infants from the NICU, which is a stable environment, to the cardiac catheter suite has its own challenges. And I'm just curious to hear your experience about how you handle IV access, intubation, thermoregulation, what you've done over the years at your center, and then talk about some innovations that you're thinking about doing in the future if it's not at your center and out in the community. It's great to have you, Sham.
Hey, Phil. Good to see you all. Thank you for having me as well. It's been a wonderful forum. So it's a great question. It's very timely as well. I don't know if you saw one of our recent article that came out. We are actually not doing these procedures in the cath lab anymore. I really do not recommend that every center does that. We are doing it at the bedside in the neonatal ICU. But we've done close to 400 patients under 2 kilograms, almost 200 babies now under 1 kilogram. So only when we got to that experience, we felt comfortable moving to the bedside. And we do not use fluoro or angiograms or anything. It's all echo guided. So all we do is take an echo machine to the bedside. Me and echo doctor will go to the bedside, we'll close the PDA. It takes us about 10, 15 minutes. So we've now done, we did our 36th bedside closure yesterday in a 700-gram baby on a high-frequency ventilator. So even though I've done now 36 at the bedside, it is still a learning process. I would highly encourage the interventional cardiology community not to go there. But it is a job of the interventional cardiology community to make sure that this procedure can be done safely, because a surgeon would go to the bedside and will travel from hospital to hospital doing ligations, whereas the interventional cardiologists still want these babies transferred in. We do have a process of transfer. I get patients from as far as 500 miles away. One of the centers that send patients is actually 540 miles. So they transfer patients on a fixed wing aircraft and our ambulance goes, picks them up. But it makes me super nervous to transfer these extremely fragile infants to our hospital for catheter closure. My eventual aim is that I can travel to all these hospitals and do this at the bedside. It makes no sense to travel 500 miles and then we do it at a 10-minute procedure at the bedside. So the future aim, I would say it's probably at least 3 to 5 years from now. I believe this can be done at the bedside by all centers. So that's number one. Number two is the complications have to be kept minimum because, as Carl mentioned, there is no study so far which shows efficacy of this procedure. All we know is it's feasible, it's safe, but we don't have efficacy. So as far as interventional cardiology is concerned, our aim is to keep the procedure complication to be zero. The Piccolo device is a great device, but the delivery system, so the catheters that we use to deliver, is still not perfected yet, in my opinion. We are actively working with the engineers within the company to perfect the device that it becomes so simple that one does not think too much about the procedure. Now, it has to be simple enough that there should be zero complication. My aim is by next year, we will come up with a slightly different or modified way of delivering the device safely. That way, this can be performed. So right now, the operators who have done a lot can do this safely, but the operators who have not done very many are still have issues delivering it safely. So my aim is eventually everybody can do this. And who knows, perhaps one day neonatologists may be able to do this. So if we make it as simple as that. So that's our eventual aim. I still think this is a very early stage in this therapy of percutaneous closure. There's a lot of opportunities to improve this therapy so that it can be done safely and at the bedside and not worry about the patient's the temperature or any vital sign variability during the transport process or during the procedure.
Thank you, Sham. I think what I'm hearing, and having just worked with the group in Boston over the last 2 years to design our program, is that you need to think about all of these different specifics that you've talked about: temperature, regulation, who's going to do it. But it's important to understand that the procedure is still evolving. While it's safe and it's feasible, what's exciting about this piece of the PDA, and in my opinion, it's the first thing that's really evolved in the last 15 years, is that it has the potential to be, a game changer. But the science, the evolution, the work that you even do in your preclinical lab is evolving. And I think it's important for anybody on this call, anywhere in the world, to understand that there's a place and then there's a time and there's a process to start even thinking about doing definitive closure. We're not doing this in very small community hospitals. I'm not going to pick a state and offend anybody. We're trying to start with big, large centers. And that kind of leads me kind of to the next part of our story that Dr. Marconi is going to kind of address with one of the question and answers from Daniel Ibros in Mexico City. So Marjorie, take it away.
All right, thank you. That was a great leading question into this question. So we have a wide audience from all over the world. And one of the questions that is asked here is whether in developing countries, it makes sense to start with bigger babies and then move on to smaller babies, or try to obtain all resources and then start a program and then start a program thereafter, and then establish proficiency and efficiency and move on to smaller babies. This question is directed to Dr. Backus.
I think it's a great question, but I'm going to punt. Sham has, over the last 10 years, built a world-class program. He would be probably the preeminent expert to talk about the initial learning curve that him and his team overcame, and now where they're kind of leading the charge on.
Yeah, thank you, Carl. I'm happy to answer that question. I absolutely encourage any site, not just developing countries, even within the states, any site that is starting out to start with larger size babies and get comfortable with the procedure before you slowly work your way down to the micro preemies. The procedure itself is not complex, but micro preemies, I mean, the neonatologists know better than I do, they are not very tolerant to procedure. So unless you're very comfortable with the procedure in a larger child, I don't encourage just going straight to the micro preemies. So yeah, build your experience, work your way down slowly. And as I said, once we establish efficacy, then we could say that, okay, this can become standard. Right now, we do not know whether what we do is changing their overall outcomes. So till we establish that, I think we should be pretty careful who we select to do this procedure on, and not for everybody. I hope that answers the question.
Yes, Shyam, that's I think a perfect response. I think just as a follow-up, just as a prelude, in a few minutes, I'm going to have Patrick do some grilling, asking of some questions to Shyam. But I think it's important for everyone to understand that in the cardiac cath suite, and even before, based on echocardiography, the morphology of the PDA, which we'll hear more about, can dictate the amenability or the eligibility to place the device, and also the weight of the baby and the different techniques that are available. And it's important to understand that the procedure itself, the techniques, and Shyam, you can just shake your head. This is not new. You've been doing this in other patients. You've been doing this in older patients. It's just the device and then some of the sheets are become smaller and more accessible in the younger infants. So the long of the short is it's not simply a baby's eligible for device closure. There are a lot of other features that are involved. And we hope that that's the takeaway from this excellent talk by Carl, that there are so many different features that go into it that is multidisciplinary and includes both the neonatologist and the cardiac cath, nursing, respiratory therapy. But what I have actually learned over the last 3 or 4 years, it also includes the pharmacist. And some of the work that Bonnie Jasani has done up in Toronto has centered around Tylenol. And I'd really like to get a sense from him on his perspective on the use of Tylenol. We heard Adrian talk about Tylenol as a first line medication to augment closure of the PDA out in Iowa. I think we all know that 2011 is when Tylenol first made its way on the scene for the PDA out of Israel. But I'm curious to know where we are going with Tylenol and how this plays into the paradigm of percutaneous closure, as well as just the overall treatment of infants with a hemodynamically significant PDA. So Bonnie, it's great to have you, and I'd love to hear about the work that you're doing.
Thank you for that, Philip, and thank you for the stimulating talk, Carl. It was really helpful to see all your body of work from the start till date. And so with regards to Tylenol, we recently finished our Cochrane review on use of paracetamol for treatment of PDA. So, and it's going to be launched soon in 2 weeks or so. So essentially there are 26 trials conducted till date. And there was almost an explosion of trials since 2011 without much effort to discover the pharmacokinetics and the pharmacodynamics and what would be the ideal dose, which could be safe and efficacious at the same time. So I would like to break it down into what is being used. What is used is 15 mg per kg per dose Q6, which is essentially the antipyretic dose, and the duration has ranged from 3 to 7 days. So for early therapy, when I say early, babies who are less than 7 days, the duration used is for 3 days, and there is more and more emerging evidence, especially one of the trials is from Memphis and one from Italy, which has shown that in the extremely preterm babies, especially in 26 weekers and below, the efficacy of Tylenol is pretty low at this current dose. So learning from our ibuprofen PK/PD studies, where we devised a higher dose beyond 7 days of life, maybe we even need a multi-center PK/PD analysis to determine what is the right dose of Tylenol to effect closure. Beyond 7 days of life, there is one trial by Dr. Klakow, where he's used 5 days, and there is more emerging evidence that longer therapy can have more efficacy and better rates of closure when used as late treatment for PDA. So currently at Toronto, we are using 3 days when the babies are less than 7 days of age and 7 days when they are more than 7 days of age, taking into account that metabolism, clearance, or both, they mature as the baby, they grow older, and you might need a higher cumulative dose to effect ductal closure or to effect ductal hemodynamic insignificance. From safety, it is absolutely safe. There is, out of the 300 babies where we have given Tylenol in Toronto, there is not even a single report of hepatotoxicity. And from the 25 trials conducted till date, there are no reports of hepatotoxicity or liver failure documented with Tylenol, with the current high dose which is being used. So there is a lot of work which needs to be done, and it's certainly we need to figure out, especially the dose in our smaller babies.
Thanks, Bonnie. That was excellent. It seems that Tylenol has obviously less side effect profile than the COX inhibitors.
Yeah.
But the work that you're engaging in are going to answer some of the questions when babies are less than 26 weeks, what the proper dose is. We all use 15 milligrams per kilogram, what the length is. A lot of us use 3 to 7 days. And there's data to say that enteral is better than IV if a baby can tolerate enteral, but all of these still need to kind of be teased out. What I'm hearing and happy to be hearing is that all of you who are engaged in this high energy and really in-depth research are also willing to comment and state the unknown. You know, Sham told us about the evolution of the procedures. What I also find extremely interesting, and Carl, I'm not going to make you answer this question. I'm going to actually punt it over to Adrian. But basically, the thought process when we started down the percutaneous closure several years ago was that if you use a device, babies won't have low cardiac output syndrome afterwards. They're all going to be fine. There's no risk. Everything's perfect. But what we're learning is that there is some risk. And we're still learning the field. So I want to throw it over to Adrian, and I want her to talk about some of the phenotypes, the cardiac phenotypes, the respiratory phenotypes, after you close the PDA, either by PDA ligation or even with our new transcatheter device closure. So Adrian, I'm curious to hear about the work that's going on in Iowa and your approach to managing these phenotypes after closure.
Thanks, Phil. The original work was done by Patrick's group in Toronto after PDA ligation, surgical ligation. And there were basically 2 phenotypes. The classic one was with low cardiac output state, presenting with systolic hypotension, low cardiac output, poor perfusion, and need for inotropes after closure. And the second part of this phenotype that came with or exclusively separated from it was a respiratory phenotype with increased need for oxygen and worsening ventilation, probably secondary to diastolic dysfunction, increased LV afterload, and secondary pulmonary edema within 8 to 12 hours after surgical ligation. And even within the surgical population, due to the suspicion that this was related to the changes in loading conditions, particularly a drop in preload, but mostly the increase in LV afterload. The institution of a mirinone prophylaxis approach actually improved a lot on the surgical patients, and most of them did not have the full spectrum of the disease anymore, and the incidence of needing inotropes or developing low cardiac output state and hypotension decreased substantially in these patients. But there was still a proportion of babies that, despite this type of therapy, still had the respiratory component of it. So when we started doing percutaneous closure here at the University of Iowa, even though percutaneous closure is less invasive and there's no thoracotomy, there's no retraction of the lung, we predicted that the changes in loading condition to the heart would be the exact same as the surgical ligation patients. So we basically extrapolated the same protocol that we were doing for the surgical babies, and we continued doing it for the percutaneous babies, meaning that we do an echo after the baby is closed within the first hour to measure their left ventricular output, and then decide which babies are at higher risk for developing anything along the post-ligation closure cardiac syndrome phenotype, whether hypotension or the respiratory component. So we have a very high use of mirinone prophylaxis within our institution, which we don't know if we are doing the right dose. We don't know if we're targeting the right babies, because we basically extrapolated from a different procedure. But what we do notice here, as well as some other reports in the literature, that it seems like the percutaneous closure babies do not have as much of the cardiovascular instability that we used to see in the surgical patients, but there still is a good amount of babies who develop some sort of respiratory instability, primarily as an oxygenation failure within 12 to 24 hours after the procedure. So that's kind of what we are studying at the moment. We have one of our local data that is currently under review, and hopefully we'll get that out soon. And we're also doing a multi-center study with Nationwide and Sham and Bonnie at Sick Kids to look specifically at this phenotype of the respiratory instability in percutaneously closed, extremely low birth weight babies.
That's extremely fascinating. I see Carl leaning in. I recall, Carl, a study maybe from 2017 where you showed that this low cardiac output phenotype still exists, but in babies less than 3 kilos. I'd like to just get your thoughts on this. When we think of primary outcome and the PDA, we often think of it closed versus not closed. And then I'm just curious, in the pivotal trial, what are some of the outcomes that you're looking at? Is low cardiac output as an outcome? Should we just be focusing on long-term neurodevelopment? Who cares if they have some respiratory change? I'm curious to think about the exposure and the outcome the way that Carl Bax thinks about it.
Sure, and I just, great question. Adrian just gave such an eloquent response regarding outcomes following, cardiorespiratory outcomes following percutaneous. I think the work to look at this systematically with consistent surveillance protocols is really going to benefit the community, because I agree. I think surgical ligation got a bad rap compared to percutaneous closure as the new savior for definitive ductal closure, without really looking into the potential adverse cardiopulmonary outcomes of post-ligation cardiac syndrome following catheter-based closure. So broadly speaking, for pivotal, the primary outcome, again, that's just a study that we're looking at percutaneous closure versus conservative management for infants who failed drug therapy. So the primary outcome for pivotal is just days on mechanical ventilation. So they're actually days free of mechanical ventilation to have the computed risk of death. We thought that was an important primary outcome based on the observational studies from Sham's group, from Cedars-Sinai and others showing improvement outside that initial 24 hours. Improvement of respiratory status post-catheter. Are we very interested in other cardiopulmonary and safety outcomes? Of course we are. Now, across the 22 sites, given that we're just looking at that subgroup, we're not going to be powered to look at anything other than days on mechanical ventilation, but that's become a very pragmatic primary outcome for multi-center trials. Given that Patrick is a collaborator in the study, he's pushed us to make sure we have consistent echo surveillance, both at the time of closure and at 36 weeks to answer questions regarding pulmonary hypertension. So I think those are the kind of the outcomes that we're looking for.
Great. I want to be able to leave some time for some questions from Patrick, but there have been some excellent questions in the Q&A that I'm going to answer, then throw it over to some of our panelists to add a little more context. With antibiotic prophylaxis before device closure, the answer really relies in the cath suite and the cardiac anesthesiologist. I know in Boston, we do just some skin prophylaxis before and a dose afterwards, but it's important to understand that any baby undergoing a GI or GU procedure within 6 months following placement of the device, the recommendation from the work that was originally done by Sham and Carl is that you should be doing SBE prophylaxis, and we're always happy to share those protocols. And then the other question, which Adrian, I'm going to throw it over to you, came from an anonymous attendee. How would you define this, conservative management? Carl has talked, as a non-intervention management or a medical management that doesn't include pharmacotherapy. So maybe just talk about the ventilator, the diuresis, and the fluid restriction, and what your approach is in Iowa based on where we are with the literature.
Yeah, I think it's important to separate to say that it's not non-intervention, it's more of a shunt modulation. While we may not be providing active medical therapy, we're still thinking about the PDA and doing things that may modulate how much shunt there is. So the things that we recommend are optimal lung inflation, so trying to optimize the PEEP and the ventilator strategies. We recommend avoidance of anemia, thinking of Poiseuille's law to have normal hemoglobin and a normal platelet count to optimize the viscosity of the blood. And also avoidance of hypocapnia as just keeping a CO2 within the normal or slightly higher range to modulate pulmonary vascular resistance. We don't routinely recommend diuretics nor fluid restriction because, as you guys know, you can't only dry the lungs. If you dry the lungs, you're also drying the rest of the baby. And if you have a shunt that is significant, it will be decreasing the systemic perfusion already. So if you are also doing aggressive diuresis and aggressive fluid restriction, you might compromise systemic blood flow and predispose these babies to other problems related to shunt, such as necrotizing enterocolitis or acute kidney injury. So those are the shunt modulation strategies that we use here that are beyond medical therapy itself.
Great. So that's extremely helpful to understand that it's the PEEP, the ventilator. There's some fluid restriction. You don't really want to go below 120 because that can have the negative effect on the systemic circulation. And then some diuresis is, if it's appropriate. I know there are centers like my own that we try and avoid Lasix for the potential impact on the prostaglandin pathway in the kidneys. Some newer work coming out over the next couple of years on that topic. I will answer one question from the chat, and then I'm going to hand it over to Marjorie to ask a question to Sham, actually. But from one question that came from Amir, how often do people try the combo therapy with ibuprofen and Tylenol? I think that's a whole nother hour and 15-minute discussion, but the long or the short is I know that there is a unique prospective kind of a randomized control trial beginning to look at different arms of Tylenol and Tylenol plus ibuprofen. So I think the data is not yet available for us to make concrete comments, but the idea that you are trying to look at both the POX and the COX pathway and the prostaglandin synthesis pathway is a novel approach. And I think just as Sham and Carl have brought percutaneous closure to the forefront, it's incumbent on everybody in the field to find novel ways, if appropriate and equipoise exists, to augment closure of the PDA. I will add one comment to help kind of frame the discussion. At least in Boston, our approach is to close the PDA in the least morbid way possible. How you define that, I leave to each of their own. But I'm going to hand it over to Marjorie to really kind of hone down on a comment that Sham made about doing device closure outside of the cath lab. So Marjorie, take it away.
Thank you, Phil. So Dr. Sham, there are some interventional cardiologists who were wondering what the reason for changing from doing the percutaneous closure in the cath lab to the NICU. They understand that the issue, there's issues with transport, cold stress, and they're wondering if there were complications in the cath lab that promoted that move, or since moving to the NICU, have complications decreased or have outcomes improved, or have you noticed any specific differences there?
Thank you so much. I think that's a wonderful question. Our intention was always to do this at the bedside. We just did not feel comfortable enough till we got almost 400 cases under our belt to go to the bedside. Now, the one paper that I think Carl kind of highlighted in his talk was our paper of 100 babies of less than 1,000 grams, and our complication rate was 3%. I must say those 3 complications were fairly early in our experience. The last, I would say maybe 200, 250 patients, we have not had a complication, touch wood, and hopefully it will stay that way. So it's not because of complications. Our bedside complications have again been 0% so far. We've only done 34 at the bedside. I just want to add a couple of other things as well. Now, the FDA actually came out with a statement last month of use of iodine-based contrast in babies, especially those under 3 years of age. And we've noticed that as well. When we use contrast for angiograms, which is typically done in the cath lab, there has been incidences of hypothyroidism secondary to contrast use. We've had at least 2 patients who developed it. So one thing we did was we decided not to use contrast. About a year and a half ago, we stopped using contrast agents. So that's when we switched to, okay, if we don't use contrast, do we even need a fluoro? So should we just do it under echo guidance? And now when we move to the bedside, we got some experience doing echo guided closure in the cath lab, that let's go to the bedside with echo guided closure. So one of the biggest reasons was, yeah, we don't want transportation of babies. Number 2 is we would like to go to because we are a children's hospital, so no babies are born here. So we would like to go to all the birthing hospitals and do this. That's our intent. Number 3 is not to use contrast because hypothyroidism in these babies can cause neurodevelopmental outcomes to be worsened as well. So we would like to avoid it. So this is not just for premature babies. It could be for any child undergoing contrast. To answer one more thing I would like to bring out, see this phenotype of post-ligation syndrome, whether cardiorespiratory, again, we noticed it very early on, maybe in the first 100 to 200 patients. The more recent patients, we do not see any either cardiac or pulmonary phenotype changes. In fact, I'm totally in the belief of if you keep the patient stable during the procedure, you do not see any alteration after the procedure. But it'll be interesting because we are part of this multi-center trial with Adrian. So let's see if Adrian shows, whether it shows that our center is different from other centers, or if it's just or maybe we're not appreciating it as much as Adrian does. So we will know that answer soon as well. So those are the points I want to make. Thanks for that question.
Yeah, those are really super important points, Sham. I'll make kind of a few follow-ups. I think that's important to recognize that's come from your work is that these babies who are exposed to the iodine with cardiac procedures, and many of us who are neonatologists, when babies are born less than 37 weeks and they have a procedure often less than 2 weeks of age, don't get chlorhexidine, they may get iodine. And it's important to understand that we have to watch for hypothyroidism. What we have a built-in benefit, at least in the United States, is we get regular newborn screens. And this impact of the thyroid issue comes usually 2 to 3 weeks after the procedure. And babies will get a newborn screen in the United States on day 2, 14 at 1 month, and then at 2 months. So oftentimes with the PDA closure by the device approach, you're often catching them. But to your point, this is a real problem that can have some major consequences, and it has to be looked after. I will add 1 or 2 other comments that came up in kind of the Q&A and other issues. Adrian mentioned, the targeted individual approach to kind of managing these babies with echocardiography and high fidelity respiratory phenotyping. I know some centers don't have the capability to do the echoes 1 hour after, or don't have the expertise of the neonatal hemodynamics clinician. So some centers are using kind of a respiratory severity score, which is mean airway pressure times your FiO2, to help guide kind of the management during and afterward. So there are other kind of hemodynamic approaches with the respiratory assessment when we close these PDAs in these very high-risk children. I really wanted to kind of take the opportunity to reintroduce everybody to Patrick McNamara. I know he's very well known to everybody on the call, but his insight from behind the scenes with the PDA over the last 25 years is another reason we were able to even have a conference like this and have world leaders talk about transcatheter ductal closure. But I know Patrick had some kind of very specific and targeted questions for all of our speakers, kind of to initiate some further discussion. So I'm going to hand it over to Patrick to kind of ask some novel, thought-provoking questions. Thank you, Patrick.
Thanks, Phil. 25 years. I was still in high school 25 years ago. I'm not around that long. Sham, I just want to remind you, this session is recorded, and you've actually just given us the reason for a second year of hemodynamics fellowship. We can now actually teach people to do the device closure. So thank you for that. We actually have your blessing here recorded. So well done. No, in all seriousness, I just want to focus on one thing, which I think is important. I think Carl has pointed this out. Sham has pointed this out, that whilst we have a intervention that is efficacious, unlike medical therapy, which you can't guarantee will be efficacious, it is not without risk. And in our center here, everything was perfect until we had the first major complication, and then everyone was looking at what now? Okay, and the question I have, the first question is, how do we define which centers should do this? And that's very, very important, particularly in the United States, where there's a financial element to healthcare, and everywhere wants to do everything and doesn't want to transfer patients. So I think it's incumbent on us as a neonatal and a cardiology community to try to define, what those centers are and what should be the numbers that a center does or an individual practitioner should do. And I'd like to push that to Sham, maybe to comment on that, particularly from the intervention perspective. And then pushing back to the neonatologists on the call, how do we build consensus around this in terms of, I think the needle has shifted fairly significantly against PDA therapy. And we're starting to learn now that, through the chronic pulmonary hypertension literature and so forth, that perhaps we went too far. And now there's a move back towards the middle. But how do we convince people that this perhaps is the right way to go? And then navigating that a major complication. When something goes wrong, how do you keep the ship afloat? So maybe we'll have you, Sham, start with that, and maybe Bonnie and Carl can comment on the neonatologist perspective.
Thank you. 25 years ago. Just wondering how I just want to see a picture of you 25 years ago now.
Oh, these things are floating around.
Anyways, from a technique standpoint, who does this procedure and how many should be done on which center should do it? My eventual aim is it should be done by everybody at every center. That's the aim, that the procedure technique should not be the one limiting the outcomes. Unfortunately, currently, the way we stand is that, as I said, like the device is a really good device, but to get that device from outside the body, inside the PDA, is not without consequence. So most complications happen not because of the device, but the other catheters and wires that we use to take the device up to the PDA. So there is a learning curve to this, and some of us perhaps have gone through the learning curve, and now we are experimenting, going to the bedside, whatever, right? But we are working as an interventional cardiologist. I am very keen in making sure that this procedure can be done safely by everybody. I am working with the engineers, not just me, Evan Zahn and a few others. We're working with the company's engineers to change some of the catheters so that they are safe in the micropremies, that the complications can be kept to a minimum. Again, I'm sure this is an infancy in this therapy, that there will be an evolution. Maybe at present, it's not for everybody, but eventually it should be for everybody. And I'm not joking when I said that it can be done by neonatologists in the future, because you all do procedures, you place umbilical lines, whatever lines and chest tubes and whatnot. This procedure should be simple enough that it just becomes another procedure that you do in the NICU. So that's my final aim, is this can be done really safely. It's not there yet. It's at its infancy. It's only, the device is 3 years since approval, but who knows, 10 years from now, we could make it simple enough that you could have a 2-year hemodynamic fellowship, train neonatologists how to close PDAs. So again, I'm not joking about this, but that's my aim, is to make this a very simple procedure. So we don't have to think, if you have a PDA to close, you do a 10-minute procedure, the PDA is closed, instead of trying a medicine that will take 5 days or 7 days to work. So that's the final eventual aim. We're not there yet.
Shyam, I love your forward thinking, inclusive, ideas on this topic. I think, just from a neonatology's perspective, let me give you my bias. I think confining it to centers that have already overcome the learning curve is one way for us as a neonatal community to actually appropriately, in a randomized controlled trial fashion, look at closure using percutaneous techniques versus non-closure. So I think over the next 10 to 15 years, you and others leading in the field will have to educate colleagues in interventional cardiology from a neonatal perspective. I think confining it to just the sites that have already overcome the learning curve, that have a feasibility and safety profile that the neonatologist is comfortable with, is one way for us to move the field forward.
Carl, that was a kind of a great way to summarize the last hour and 15 minutes. I think we could go on for another 2 hours talking about this, but I really, as I commented in the chat, I wanted to thank Carl and Adrian and Bonnie and Marjorie and Shyam and everybody on this webinar today for really contributing to what I think is a high-level, thought-provoking discussion. We've come really far as a group over the last 5 years. We have a lot farther to go, but people like Shyam and Adrian and Carl and Bonnie and Marjorie, who are pushing this field forward, is really the only way we're going to be able to ever get to the answers, to understand the equipoise, to understand the outcomes, and to best advise all of the families. This is not an exact science, but we're trying to do the best we can as we take care of these high-risk patients. So with that, I want to thank Carl and Shyam, Bonnie, Adrian, Marjorie, Lauren for all of her hard work, and Patrick for behind the scenes. I want to wish everybody a good day, a good evening, and a good night. We look forward to seeing you at the next PAHC conference, and look forward to seeing everybody in person in the near future. Thank you all.
Thank you, everyone.